Once again, good morning, good afternoon, good evening. Welcome to episode number 61, unbelievably, of the Unboxing AI webinar series by Carpal AI. Every Thursday, 11 a.m. Eastern, you will find us calling one of our collaborators, friends, customers, partners, and asking them everything we can about their journeys, about AI, trying to unbox, this so-called erstwhile black box of AI, if I may say so. If you don't know what Carpal is, well, clearly you have been living under a rock, but still, for the purposes of completeness, Carpal is your friendly neighborhood AI platform, helping you navigate the complexity of these beautiful AI applications out there, bringing them into your clinical workflows, helping you build, test, deploy, and monitor all sorts of radiology AI solutions in your workflows through a single user interface. So we've recently launched a beautiful little universal AI widget that is really receiving good traction across the world, and then through a single integration channel and a single procurement channel. But enough about us, and on to today's guest. I have the privilege of, introducing another Dr. Mahajan, which is it's quite rare on these webinars. So, Dr. Amit Mahajan, thank you so much for joining, Amit. It's a pleasure. It's an honor that you chose to come. Uh, just by way of introduction, Amit currently practices as a neuroradiologist at Yale, although he's dual board certified in radiology and internal medicine, and is also a practicing infectious disease physician. So we'll go deeper definitely into that. He's an associate professor in the Department of Radiology and Biomedical Imaging at Yale. He finished his MD from the prestigious All India Institute of Medical Sciences right here in New Delhi, and then moved over to the US. Very minimalistic bio, Amit, you have sent, I must say, given everything that you've done. But thank you so much for coming here.
No, thanks, Vidur. Thanks for the invite. Thanks for carrying the Mahajan name forward. Uh,
Too kind of you. Too kind of you. I hadn't
but
actually thought of it like that, but I will accept.
sorry for doing it like that. But yeah,
No, no,
yeah. Thanks for the
thank
invite.
you. So, Amit, as is customary in these webinars, we start by asking a very simple question. What is it that you do? As if, you were telling a 5-year-old.
Yeah, no. So for a 5-year-old, I would say that I'm a radiologist and I'm a doctor first of all, so that um, uh, so that they understand and that. But uh, I'm not a usual doctor, and where I take a stethoscope and look to people's heart and chest. I look at their internal body parts to understand what's going on inside their body. Is what I would explain and define it to them. It's funny that how I was called to my kids' school to say, okay, what do you do? And if she was in preliminary elementary school, and so I took all these X-rays to show it to them, and then they saw
Ah.
the bones, and so they're like, okay, I'm the guy who looks at these bones and tells you what it is. And then after that, we had a dance with the bones as well. So just to
That
know,
might actually not be a bad idea for even folks like us to do, who are now working in this domain. No, but I think beautifully explained, Amit. I think it's almost like saying you can see through walls, so and see through the
exactly.
body. So pretty cool. So Amit, we chatted briefly about this prior to starting. So. Residency in India, then moving over to the US, right? And Apex institutes on both sides. What's different?
So yeah, I mean, obviously worked on both sides, so I know the complexities involved in on both sides. In fact, I mean, you would think that coming from, say India, we are resource poor there, and so coming to the US, and it will like the ideal world, right? It will be something which was to which you had achieved nirvana if you reached here. But then once you can start working here, then you realize, oh my God, that these people have their own challenges and. and that theirs is not a rosy life either. I mean, it's a first world challenge, it's a first world problem, but they have problems too. And so there's a constant struggle to self improve and to improve the surroundings that we have. So yeah, it's a different set of challenges.
So let me ask it a different way, Amit. Like,
Sure,
what
sure.
what is one thing that radiology in India can learn from the US, and what is one thing that US radiology can learn from India? And I know I'm going a little bit off script, but
Yeah, well,
I'm
no,
very
that's a
curious.
great question. That's a great question. It's like I think there are things to learn on both sides, and like I mean India. I mean when I was working there, I mean I know your Mahajan estates had their first MR even before Ames had, and so I remember that when I was a resident, and so yeah, so they don't have resources to. I mean they're limited. So someone I was talking to someone yesterday, and they're like, oh yeah, they got their first MR in Amritsar in like 2000 and something. Like she was a resident there. So it's so and they were very excited when they got that one MR. And now I'm working in a place that I'm in charge of 13 to 16 magnets.
Wow.
Yeah. So yeah. So we made some progress. So definitely, how we operate more efficiently in a resource poor setting is much different than say so that's what they have to learn. I mean, you obviously are seeing, how the US is trying to cut costs now and, cut expenditure all around. And the same thing is impacts everyone. I mean, from top down, it impacts the hospitals and everything else. So everyone is trying to save money. Like, so this is the time to look at India and say, hey, something. I mean, I say that like, India is a very efficient system in which we go to a doctor, we go to an imaging center, and we tell them what we want, and we get it done.
Gets
So
done.
that's
Yeah.
like a ultimate in private healthcare. I mean, that is like, it's not good for the masses. I do understand that, but for a private person, that's great. I mean, here we have even a CEO of a company coming in and of a multi-billion dollar company, and they can't get an MR. They would have to be. I mean, I got a patient 2 weeks back, and she was like super rich person, and she was sent to a very worst of magnets, and so she can't get that done, and whenever she wants to. So it's a very different system in which the two things can definitely learn from each other.
No, fantastic. And also, Amit, like, I think you're unique in that, you're a trained radiologist, trained internal medicine person with a subspecialty infectious medicine. One, how do you split your time today? Like, what does today look like? And then two, do you see, because there has been this almost resurgence of clinical radiology as a as more AI comes in, the role of the radiologist is going to evolve, and there is that one narrative that says that a radiologist has to be much more of a clinician today, than they have ever been. As somebody who is actually that, how do you think about these two? But first, how do you spend your time?
Yeah, so spending my time, I would love to play and go on my boat, but but I have to work as well. So but the point is that yes, that as far as work is concerned, that mostly I do neuroradiology. So clinically, I'm not. I've left the clinical part somewhat behind, and I do consult for like say ID cases, infectious diseases cases, and having the knowledge of both radiology and internal medicine. I think that helps me kind of streamline the two streams together. There's a big disconnect between between medicine or surgery and radiology. Radiologist uses big words, big names, and and the doctors don't understand what they're saying, and so they, in a sense, look at the last two lines, the impression of a report, and say, okay, this is what he means, and so unboxing even medicine radiology reports is a big struggle. So that I think that's where I mean try to fit myself in that the gap in between, which I can translate that information from one side to the other and make some meaningful value for the patient. So that's kind of my niche, and this is what I'm trying to do on a day-to-day basis.
And as we think about AI coming more and more into practice, Amit, and potentially automating away some aspects of the radiologist job, do you think like having more medicine training would become kind of important for radiologists, like, or do you think it could go the other way around, where it's like pathology, right, where or blood testing, where one person is essentially signing out like 5,000 tests a day? Like, how would you think about the evolution of the role of a radiologist?
No, I think it may. I mean, just to give you a background, in 1996, I was at AIMS still, and I was reading through papers, and at that time, there was the first time I heard about neural networks, and I
Oh,
was like
wow.
fascinated.
Okay.
Yeah, 96. I remember papers from in radiology in 1996, and I remember thinking to myself, oh my God, these things are going to take away my job. And that scared me so much. And I'm like, okay, I need to have a backup plan. So I came to the US and I started doing medicine. So that was my backup plan in case things went south. And so I did. I mean, so that was my doing internal medicine, doing infectious diseases, practicing for another 5 years. So I put 10 years of clinical work in my in my CV or in my background. So even after that, after 10 years, nothing had changed. And so I came back into radiology and I started, and so that has been like another 15 years since.
What made you take that plunge? Like, why go back to radiology?
No, because I finally thought that maybe I was getting too much scared
Hmm.
unnecessarily. Maybe it was not, and I think that I found radiology interesting in a regardless. I mean, it wasn't like I wasn't interested by radiology, but I was much more diverse by then. And then, so I thought doing the radiology for a longer period of time is probably what my goal was to begin with.
So
So
radiology was your kind of first love.
yeah. So I tried medicine, and then I came back, and now I'm kind of merging the two fields together. So there are two different, these are totally two different kinds of people. And you're right. Some people do bridge the gap in between. And, um, and yeah, I think in the long term, the computers may take away some part of our job, but I think the main crux will still remain. I mean, you will need someone who can synthesize the information and present it to the clinicians in a palatable form, in a form that they can understand. So for that role, I think it will be really there. I mean, I think I've been working with some people in your group to try and make test out the algorithms for, say, spine reporting. And we are trying it out, and we're trying to see if it's usable, and if we can automate the findings part of the report, and maybe just we can focus on the impression part. So I feel that impression cannot be given away to a computer, but
Hmm.
yeah, sure, I can use the computers to make up the body of the report, and then I can give a final as a more thoughtful, nuanced impression as to, okay, this is something is wrong with the patient. Please go and do this. I mean, take care of this patient thereafter.
So that is so interesting now, because there are a lot of AI tools now coming to the fore that are actually saying that you create the report, we'll create the impression, right?
Yeah.
The auto
Yeah.
impression is
Yeah. I
or
somehow feel
smart
that.
impressions. Do you think it could be a practice area thing? Like, because you are probably getting the world's most complicated cases, right? Or at least the region's most complicated cases. Whereas, others in private practice are maybe, getting like lower back pains. So,
Yeah.
do you think it could be a function of the type of practice also, where findings versus impression, like what is more complex?
Yeah, I mean, I'm not totally been able to understand why. I mean, so maybe I'm not used the impression tool as much. I mean, I tried one impression tool and I was not impressed by that. So it remains to be seen whether it can, because I feel personally that the clinician looks at my impression, and that is he is basically looking at what and when I do a report, right? Impression is the point at which I stop and say, okay, of all these findings, what am I supposed to tell my clinician? I stop there for a second and say, okay, I make a summary in my head, and okay, what is wrong? Or if there's a spine, there are five different levels. So which level should I tell them to go and operate? So I try and stop there and see, okay, which is the most significant thing, and put that in the impression and give it to the clinician. So
Interesting.
I
So
think
it's
that is
also
the
something
most.
that cannot be created without clinical context, essentially,
Yes, exactly,
right?
exactly.
If
I
you
look at
don't
the
know the
look at the
clinical
findings.
question, then how do you know the answer? And
Exactly,
you start
exactly.
creating, that is a very interesting way of looking at it. I think this is also a call out to my team that we need Amit to test some of the reporting tools also that we now have. But that is very, very insightful.
Yeah, no, because that's even that is at the point at which point I go back to look at the clinical impression and see where is the pain,
Hmm.
or where is the problem, and then give them kind of a more nuanced opinion rather than just a cookie cutter. Let
Yeah.
the computer figure out and send something out, and then they will figure out. Not my problem, So I think that's not a very smart way of doing things, but that's my opinion, and. I think only time will tell whether I'm correct or not.
No, that's
Because I know these tools which create auto impressions, and yeah, uh, I'm not ready to give it up yet,
Yeah,
just yet.
nice, nice. No, and just switching tracks a little, Amit, and to everybody who's joined, please feel free to ask your questions. You can use the Q&A, you can just use the chat, you can WhatsApp me, whatever. Please do ask your questions. Like the whole reason we do it as a webinar is so that you can ask whatever is on your mind. So so just switching tracks, Amit, we you are also a prolific researcher, and you're engaged in a bunch of both AI and non-AI research. Would love to hear from you a little bit of what you've been up to. What are some of the things we may not have heard elsewhere, that you can tell us about, to whatever extent it's possible.
No, sure. No, thanks for that. So, Vidur, just to let you know that I've been kind of called something called an early adopter. So, so what happens is, even when I was doing my infectious diseases internal medicine stint, I would start the look at the latest research, look at the latest information, look at the latest drugs, and see what's out there. And I would be the first one to, I mean, start a patient on that new drug, try it out, if I knew that this had a new mechanism of action or something. So I'm all for trying out new things, and and see how we can incorporate that information into our day-to-day practice. So the same thing is I'm trying to do with radiology now as well, is to see what's out there and what we can use to improve our lives and improve our reporting ways of reporting things, way of making it more efficient. How we can do those things. So and I've tried to take a multi-pronged approach to that. I've tried to, streamline orderings, streamline, reporting, streamline sending out reports. So I've been involved in multiple different facets of those kind of processes, and on especially in the software, assessments. I think I've done a few of them. We've done subtle, we've done spin tech, and all anything that could help me reduce scan time. I've tried them, and so yeah, so right now we have a whole bunch of these AI algorithms that we have been using. You guys must have heard of AI Doc. That's
Yeah, of
one
course.
which happens in our system. We've started a few on MR based algorithms as well, which include like icometrics, which basically looks at the thickness of the brain, outer lining of the brain, which helps us think. So you can do that, and then you can also like MS we were talking about. It can go and
Yeah.
quantitate the white matter disease volume, so that you can follow these people over time and see if their brain is worsening over time or not. So we have been trying those algorithms as well in clinical practice, and I think we are continuing to do other things to self improve, like the spine reporting algorithm I was talking to you about.
Got it. Got it. No, and can you tell me a little bit about, you were mentioning something about non-gadolinium based contrasts, etc., like without mentioning the names, etc., There is at one side we have AI going towards saying you use 10% contrast, and we will create an image that is as beautiful as a 100% contrast image. And on the other side, now from you, I'm hearing non-gadolinium based MR contrast. How do you see that playing out?
Uh, okay, maybe this is not politically right, but I mean, 80 to 90% of gadolinium comes from China, right?
Yeah.
So what's going to
Mhm.
happen if something were to impede that flow of gadolinium? So people have not prepared themselves for that yet scenario. I mean, maybe it will never happen. Maybe the world politics will.
Correct me if I'm wrong, Amit, but there was similar issues during COVID, right? If I'm not wrong, where it was very difficult to get both gadolinium and then also some radioisotopes and uh, I don't know.
Yeah,
So
you're right.
we've
No, you're
kind
right.
of
I mean,
been
there
through that.
was.
Yeah.
You're right. You're right. We went through a stage in which we had lost CT contrast. At which point,
Yes.
that was
Yeah.
the first time in the US when I saw people trying to save contrast. I've never seen in this country people trying to save contrast. It was like flowing. The contrast would be like used like water. I mean, they would waste it. I mean, they would. No one would care how much 5 cc they took out of a 70 cc vial or not. It was immaterial.
Through the full while.
Yeah, so that would never happen in India, right? In
Yeah.
India, I remember as a resident, we used to tell patients to go and get 2 ampules of contrast from the local pharmacy before I could give it into a patient. So, from there to like indiscriminate use of contrast, and then finally, I think there was some degree of rationality developed in which like people were thinking, okay, so what is the optimum amount of contrast I can use to take care of the scan? So yeah, the same thing with gadolinium, right? I mean, could be should we have alternatives to gadolinium? And I think that's the where we fit in is like reduce the amount of gadolinium, maybe also try other materials which can be used, maybe say manganese or something. I'm not
Yeah. Oh
aluminum,
wow.
manganese based
Interesting.
contrast. So there are a few trials out there which are trying to do those kind of studies.
Nice. There's a few questions, Amit, that have come in. First one I'll take is from Dr. Suresh Mukherjee. I'm sure you know him. Thank you, Suresh, for joining. Means a lot. He asks, in the future, do you feel post-processing MR and CT algorithms would be provided by standalone companies? So, say the likes of Subtle Medical, or there's one from India that's amazing, AI Kinist, Clarify, etc. So, would these algorithms be provided by standalone companies, or they would be integrated into the OEM equipment itself, or both?
I I mean, Suresh is much more knowledgeable than I am in these topics, and but I think the future would be probably that they would be bought over by the big. I mean, I think that's just what is happening, right? I mean, Subtle came out with this thing, and suddenly everyone else is doing it, right? Or they go and create their own product, or they'll buy up the company and take over their technology or something.
Yeah.
So, I think I mean ultimately, I mean, whatever new thing that we try, it ultimately gets bought by the behemoths like Siemens and GE or something, and made into their as if it's their development.
Got it.
And
No, I think it's that's very, very pragmatic kind of outcome if one was to think. Next is from Ridhima, who's a young physician on our team. She's recently joined. Thank you, Ridhima, for your question. She asks, given your experience as both a physician and a radiologist, I'm curious what growth and innovation would you like to see in the field of healthcare AI, not just imaging, to keep up with increasing efficiency needs, basically. So, outside of imaging, what else do you see happening?
I think there's a lot of processes which need to be streamlined, which we're not there yet. I mean, we talk about medical records, and medical records are so complex right now, and they are not streamlined. They're not easily extractable, and we talk about LLMs and all that stuff, and can they be harnessed to to data mine and stuff. I mean, we talk about it, but I've not seen a meaningful development in that space. Yes, I think there are plenty of opportunities, and I'm sure there are people willing to pay good money to improve the efficiency of these systems.
Yeah, I think
Yeah,
one of the things that is happening there is, Epic has come out with their own marketplace that now has a bunch of AI solutions. I think, starting from like drug recommendations and, then sepsis detection, I think is one that has been very well studied. So certainly, there's not enough radiologists, there's not enough oncologists either, there's not enough, surgeons either. There's really a shortage across all spectrums of healthcare. It's just, I think radiology being digital comes to the fore much sooner in this domain. Next is a question from Aditi, is also a part of our team. She asks, "Hello, Dr. Mahajan. As a radiologist, how much involvement of AI do you like in your workflows? Like there are many different AI solutions that give many different types of outputs. Some solutions mark the abnormality, some solutions just tell you that there is an abnormality, and some give you a detailed report of the abnormality. How much involvement is appreciated by a radiologist? I think that's
as much as possible.
as much as possible.
As
Interesting.
much.
Wow, I
I
would
mean,
have
whatever.
thought the other way around. Ah,
Why not? Although I must remember that I think Suresh mentioned in his webinar 2 weeks back, maybe, in which like that who is going to be benefiting from all this?
yeah.
And that's a very good question: is who is going to be benefiting? Is it going to be the us, or is it going to be the companies that make the algorithms? Or that's the thing. Is like I think then maybe there's going to be redistribution in which some of the I mean, but ultimately, I think the ultimate will be that probably there'll be a fewer number of radiologists on top, and they will be able to manage with a fewer number of people, and that may be a thing that may happen. And then some of these whatever the resources may go towards these companies which will provide the solutions. And I think that's why I said as much as possible is whatever
Yeah.
we have to do to make it more efficient and accurate, right? We can't radiologists don't want to give up accuracy. I mean, that would be bad for
Yeah.
healthcare or
Yeah.
patient care. And then efficiency is what we are looking for, with definitely a high level of accuracy, which we are not there yet, but I'm hoping. I mean, maybe it's not a good hope to have, but
No, of course,
but
it is a great hope to have, no, Amit, because you imagine a patient in Arunachal Pradesh in India having the same level of care as New Haven, right? So it's a great aspiration to have. Just in the interest of time, there's one last minute question that's come in from Gaurav, who's again from our team. Uh, so he's asking, he's new to healthcare, so he's asking, I'm curious to learn about some examples of comorbidities creating contextual differences in the interpretation of pathologies on scans. So how does the presence of a comorbidity change how you look at an exam? Just some
uh,
examples.
I guess I'm trying to say, okay, so yeah, so I think what you're trying to ask is, do I need to know the clinical information when
Correct.
I'm
Yes,
interpreting,
yes, yes,
right?
yes.
So I think that's very important. And I mean, we use, like as you said, mentioned Epic. So Epic is our kind of our healthcare EMR, and knowing what is there and how do we get the comorbidities in a kind of a decent manner, which will help us interpret, is what we should be doing. And I think this is where LLMs might be a useful tool, again,
Hmm.
in a much better manner than, I mean, right now in Epic, you can see that every patient has a snapshot of like their problems, and
Yeah,
it's like 100 problems. They
yeah,
can be in, and they may be all garbage. I mean, they are 50% of it is totally bad information, and some of it is not updated or anything. So there is a lot of their opportunity there to kind of create a good solution which will kind of sort through this information and create meaningful information which can be useful to us as radiologists when we are interpreting our scans. So right now I have to sift through it manually. I have to say, okay, the way I do it is I look at who's ordering the scan. I go to the note, I look at the note, and then I say, okay, this is what he saw on clinical exam, and then this is what he's looking for. And so that, but then again, if something were to automatically show it to me on my screen, that would be so much useful then, you know. So maybe a linkage between, say, my PACS and my EMR, in which the EMR spits out the clinical note from that day when this scan was ordered.
No,
Maybe a good.
that's great, and I think like I said, we try to end on time, so we are at time. I can keep asking you questions for a very long time, but thank you, Amit. Thank you for joining. Thank you to everyone who joined. It's incredible. I think we had one of the highest turnouts today. Uh, so thank you, Amit, and thank you, everyone. See you next time, same time, different link. But, great.
Thanks,
See
Vidur.
you.
Thanks for having me.
Thank you, Amit. Thank you so much. Yeah. Thank you.